Moving on now, gives me great pleasure to introduce our first keynote speaker today, who's travelled all the way across the pond to be with us. So we're very excited to have Professor Eva Szigethy here with us, who's going to talk about her work with IBD pain.
So I'm a psychiatrist from University of Pittsburgh, and I direct a multidisciplinary program in our IBD center at University of Pittsburgh Medical Center. And I'm going to be telling you about that program. It's a medical home model. But I really wanted to start with just, responding to Lucy first. I mean, your story so powerful and so much resilience there. And I mean, I think that the gist of my talk in focusing on behavioral interventions is really that sort of, the research looks at the masses, the research sort of looks at means and standard deviations, but how important it is to really listen to our patients, hear their story, hear both the drivers of their pain, but also the sources of their resilience, and help them optimize that resilience. So thank you for sharing that. And that was beautiful. And it's wonderful for you to, have fought the fight and be reaching for your dreams. So thank you. All right. So treating chronic pain in inflammatory bowel disease. So I'm going to talk about my integrative model, but I'm going to take a step back first and talk about the psychological treatments that have efficacy support, and then how do we make them available to our patients with inflammatory bowel disease. So this is my conflict of interest. None of this affects what I'm talking to you about today. So in this room, this is filled with experts in terms of talking about acute pain, chronic pain, different mechanisms involved, and then the consequences. So, acute pain, I think that, the IBD docs are really, the gastroenterologists are experts in looking at the mechanisms, and often for the acute sources, you can actually do something medically or surgically and make the pain go better. I've always been struck that we call chronic pain as pain that lasts longer than 3 months, because 3 months is really no time at all. But in fact, there's a whole body of literature showing that once pain becomes as chronic as only 3 months, you start having actual sustained changes in your nerves, in your spinal cord, and in the brain. And then if we superimpose that on your life experiences and trauma that you might be exposed to, or just the repetitive stress of daily hassles of life, that is sort of a further wear, sort of an allostatic load of sorts. And then now we start having not only the pain itself, but the secondary consequences, the ongoing anxiety, depression, suicide, post-traumatic stress, again, if it's overwhelming for a person, substance abuse dependence, sleep disturbance, all of this leading to more and more physical disability, which drives the cycle, social isolation. So much now, not just pain, but now the suffering consequences. So chronic pain, as we've heard already from our experts, is complex and multi-determined. Very high rates of anxiety and depression. And you don't have to have a diagnosis of anxiety or depression to have that state of mind, even if it's transient. Sort of flood your brain with pain perception, increased severity. And I'm going to really talk about the history of early life adversity and trauma as an area that I don't think we focus a lot about. And then, as Lucy's story really beautifully demonstrated, the traumatizing effect of the pain itself and how that actually changes our brain. And we need to pay attention to that in all of our treatments. All right, so here, in terms of just thinking about, you have some source of pain in the gut, and that actually, again, once it becomes chronic, you have neurogenic inflammation. And, I think a lot of this we can't capture yet in humans, but just because our primitive tests don't pick it up, doesn't matter. It doesn't mean that it's not there. Peripheral sensitization. Like I said, quickly you have central brain sensitization. And the beautiful thing about the brain, though, is that if you can sensitize it, you can desensitize it. So our brains are very resilient, and I think we have to think about it in that way, about what can we do with our treatments to take advantage of its neuroplastic ability to activate different pathways. But here, if you have the pain, now you're going to have the secondary effects of that brain sensitization in terms of the pathophysiology. Now you have more disability going on. The disability is leading to secondary changes. Now it's not only your gut, but if you're not active, you're going to have muscle atrophy. You're going to have other kinds of parts of your body, even bone loss. Your immune system is now further compromised, and all of that driving this round and round. So, I think just in a general way, even though I'm a psychiatrist who practices behavioral therapy first and then prescribes medication. So even as I think about my psychological interventions, I have this plan, and actually I will give this handout to my patients, and we go through this, and we put in their symptoms here, because I think we've heard already how important it is to validate somebody's experience, but to let them know that, we don't obviously have it all, but we have bits and pieces of this picture that we can start applying to you as an individual. I talked about the brain itself being traumatizing. So if we think about our brain, our main purpose of our brain is our survival, keeping us alive. So really, if you take that, again, in a general way, it's to decide what's safe and what's dangerous. When are we safe and when are we in danger? If your own body is basically betraying you and constantly sending you pain signals, regardless of what else is going on in your life, your reptilian brain, your brain stem, is going to be primed to be always on danger alert. Once you're on danger alert, fear and anxiety are going to be pinged in the limbic system, because that goes along with, I don't know if I'm safe, I better be ready to react, and that then leads to our cognitive neocortex suffering, and the suffering coming across in many ways. So again, this is primed by the autonomic nervous system, by our adrenal stress response, but so important to think about how are we going to change that brain state to allow the brain to find ways to become safe again. And in that safety mode, even if there's signals coming from the periphery, how can we help the brain literally not be there to catch that brain ball, so to speak? Another way to think about this, and this is very far away from the basic science, but I really do think about pain as you have a stimulus in the gut. It's really the brain that decides how you're going to perceive that pain and then how much suffering you receive. And yesterday at dinner we had a very interesting conversation about sports, and in many sports you actually are fighting your lactic acid pain threshold, and how different it is when you're choosing to induce pain, and how I'm a lifelong competitive rower, and at the end of the race, how different my pain is if I've won or if I've lost. Just that little fact, and pretty much the same amount of effort. Again, showing the power of our mind to modulate this. And again, what are our biggest signal modifiers? It's really what we think, what we do, our behaviors, and then, again, the emotional state, or positivity, or optimism, or relative pessimism by which we approach all of it. So when I think about pain targets now, really with any modality, but especially the behavioral interventions, thinking about how can we target this flow here of how thoughts, behaviors, feelings, and physical symptoms are connected, which way somebody's natural course is driving this, and how we can reverse that, and then where do the environmental factors life adversity, life stress fit in to, again, push that in one direction or the other. So when I think about how to go about pain as a clinician, and I'm fortunate, I am responsible for about 800 IBD patients in my program, and in that role, like I said, I do have behavioral therapists who work under me, social workers, psychologists, but I also jump in and do therapy first and medication second. So thinking about brief empirically supported behavioral interventions, thinking about how do we give patients access to those interventions, because there's not enough, even if we knew perfectly what to do, there's not enough behavioral health providers to give this. So I'm going to talk about how we use health technology in the States to achieve that, and then how do we take all of that, integrate it back into a multidisciplinary team approach where we can take what's out there at large and apply it to our individual patients and their very personalized stories. So the most sort of evidence-based interventions for chronic pain, and now I'm going to go and take a step back and do that horrible thing and also incorporate the irritable bowel syndrome research, because that's really, unfortunately, still where we have the most evidence. But actually, if we look across pain syndromes in humans, chronic pain syndromes, cognitive behavioral therapy, hypnosis, and mindfulness meditation, these are all ways that we modulate how our feelings, thoughts, and behaviors are connected. We just do them from slightly different lenses and using slightly different methodologies. Cognitive behavioral therapy has actually gotten a bad rap, I'd say, in the last 5 years for being too negative focused. And so some of the variants, acceptance and commitment therapy, actually draws upon many of the same principles of teaching people a different way to think, different ways to behave, and all types of these therapies are based on practice. So maladaptive patterns of coping have evolved. Often people aren't even aware of their cycles. So helping them become aware of the cycles, finding the points of reversal in the cycle that matter to them, and linking that to where they want to go in the future. So again, helping to change both the lens, but then giving some kind of recipe and having some ability to individualize this in a way that helps somebody. And when I train my therapists, because I am fully trained and do the training in cognitive behavioral therapy, hypnosis, and mindfulness meditation techniques, I really talk about these behavioral interventions as work with someone, and just like you wouldn't keep someone on a medication if it hasn't had an effect, you don't keep someone on that track of psychological treatment if it doesn't work. And luckily, there's a lot of different lenses, a lot of different ways to look at things. And so, again, all of these involve an unlearning and a new learning for the nervous system. All these modalities have about a medium efficacy slide in large samples. And again, it's a matter of then taking that knowledge and applying it to the individuals. Cognitive behavioral therapy, here are some, and again, I think this group is aware of some of the kind of cognitions that go with chronic pain, emotions of depression, anger, frustration, anxiety, further driving the pain, poor sleep, fatigue, tension, shutting down, avoidance behaviors, and then that making the thinking and worry about the pain worse. So vicious cycles that can be reversed. How do we make these behavioral interventions accessible? So we use healthcare technology. So in my program, we make all of our behavioral interventions available by telemedicine, telepsychiatry, so that the patient can be anywhere they are, and they have an app that gives them a portal into their appointment, and we can interact with them. Our interaction actually is the video that we come up on and that we see the patient on is embedded in our electronic medical record. So when I see a patient, the medical record is right there in front of me in the screen, and I can actually look at things, navigate things. I can look at, in the remote monitoring of patient-reported outcomes, it's the same portal that we ask patients in their home environment, so not in clinic, to track. We track things about a monthly basis, what's happening with their pain, their anxiety, their depression, and that comes right back into our electronic record to be available for us at these visits. I'm going to talk a little bit more later about the clinical analytics we use. So we can take our group of a couple thousand IBD patients, and weekly the system updates everything that we put in different fields in the medical record is available for us as probable data. And then last but not least, we use coach-enhanced digital tools. So apps, actually one that we developed in our system that allows patients to literally have skills in their pocket on their phone, and it comes with a coach that we also train, and coaches that text the patients and can monitor their usage and also their progress using these tools. So this is our digital tool. We called it Brain Manager. Actually, I got to name the tool, and I call it Brain Manager because I really do a lot of education with my patients about the brain-gut axis, and that your brain is your most important extraintestinal organ to help your IBD. And as such, we need to help your brain manage your gut better. And so even how we don't say to patients, oh, you're anxious or you're depressed, and this is going to help you. We need to give you tools to bring your brain fully online to fight these IBD symptoms, including the pain. So it has relaxation, mindfulness, cognitive, behavioral skills, exposures, distress tolerance. And I've made this relatively theoretically agnostic. So we have dialectical therapy, we have acceptance and commitment skills, we have more classic cognitive behavioral therapy, we have mindfulness, because I want this to be a toolbox for patient, and then they're working with the coach who is texting them, and you see some examples there. And probably about 2 to 3 times a week, the coach texts. And these coaches are not mental health trained, licensed professionals. They're actually, my favorite coaches are new college graduates who are eager, who want to help people, who are good communicators. I don't expect to have them lifetime. I expect to have them for 1 to 2 years. We've set up a coaching academy for them. And each coach, once they're fully trained, which takes about a month, can handle a load of 500 patients because you're texting. So, and then everything that the coach does, and I'll show you that in a minute, is available in a computer portal, so they can pull up each patient and look at the various areas of progress. This is just an example of, when you're developing these tools for patients, you need to make it easy to use, you need to make it visually appealing, you think about the text size, font, and the amount of text is not too much. So it actually is an art in and of itself to take manualized 50, 60-minute therapy sessions and chunk them in a way that we all interact with our phone. And how do we all spend hours on our phone. How many of you guys have Google or whoever in your phone tell you how much time you spend on your phone? Well, I'm amazed that I spend 5 hours, daily on my phone, but it's in like 30-second to 5-minute segments. It's not all at once. Part of that, I have to defend myself a little bit on this, is that all 800 of my patients also have my cell phone to text me, including here. And that's just something that I've chosen to do as a provider because you can't predict when people are in psychological stress and need you. And that actually gives my patients comfort that they can, for the most part, reach me. We also are constantly putting new material. So our human brains like to be new. We like to have new things, new images. And then we're also now just upgrading with videos. And the app has a place where you're actually tracking your goals. So we purposely didn't call it the problem section, we called it your goals section, even to make this tool something that helps people go into the future. And if I can have Wi-Fi access, the code, because I couldn't get the password, then I'm happy to, I have it on my phone, so I'm happy to show anybody who wants to see this at the breaks, right on my phone, how to use it. This is the coach's dashboard, so the coaches can pull up a user and see exactly what techniques they've completed. The coach can, in interaction with the user, decide that, oh, you don't need the next thing up in your queue. You might benefit more from this or that technique. And so the coach can individualize this program for users. And then I'm the one that actually supervises the coaches. And so if there's a clinical decision to be made, I'm right there in there. They present the case to me, about 10 minutes a case, and we decide if there's further individualization needed. How does this work? So a patient comes into our IBD clinic, and we give them a tablet, and when the tablets don't work, because that happens, we have paper pencil backup versions of our screening instruments. And if the tablet works, then it is automatically scored right in the electronic record. If there's a score of anxiety or depression, and we just added a pain alert, it actually sends an alert to the gastroenterologist to say you should think about prescribing some type of intervention for anxiety, depression, or the stress related to pain. We can order it right in our medical record the same way we order medications. So we have a digital tab built in. You click on that. Only thing you have to do as a doctor, as a gastroenterologist, because we don't want to slow up their flow of the day, is confirm your patient's cell phone number. Because obviously that's where they're going to get their unique code, and that's where they're going to get the instructions right there before the patient leaves. They download this, and it really is so powerful to have the medical team reinforce the importance of this. So on purpose, it's not me, the psychiatrist, ordering this. I work and train up my gastroenterologists and medical nurses to prescribe this to our patients, and then the patient can start right away. The patient's information of what they do in a more general way also goes right back to their chart, their medical record chart. So the next time they come in to see the gastroenterologist can see, did they download it, are they using it? And we really have run about, not all IBD, because I'm testing this in other populations in our hospital, but we have already data on 10,000 users in our system, and are able then to look for trends, look for further ways to personalize, and start linking behavior within learning coping skills to some of the more objective kinds of data that we collect in our medical records. For doctors to buy into this, for patients to buy into this, you need data. People still like randomized controlled trials, so we run randomized controlled trials. This is just 90 patients that had access to this app as part of their IBD care. So these are IBD patients versus patients who actually just got supportive therapy for 3 months from our social worker but didn't get any skills training. And we saw a really significant, clinically significant improvement in anxiety and depression. And 75% of patients actually use this app in a meaningful way. Anybody who is a behavioral health practitioner, that's huge. You usually get about 10 to 20% follow-up, even if you have a resource available. And I was very interested in how much I could offset my social workers to do other things, or again, to see more patients. 68% increase in their efficiency, because now they could explain this app to people in a little more detail, and then let the tool, the digital tool itself, train in the coping, and the coaches can tap it along and then only step in for patients who are struggling or needed further individualization. So how does something like this work in our team-based approach? So a medical home model is coordinating patients' health really across their lifespan. So in our model, we have 16-year-olds, and then the rest of their lives can come to us and be patients in our home. And the whole model here and the change that we are trying to make is, instead of making our care reactive, so a patient is already at their disaster point, either having a flare or in a psychological crisis, that's when we hear from them. We want to get them more to become better self-disease managers and be preemptive and help prevent sort of more catastrophic outcomes, and then incorporate the technology. So, a paper had just come out this year in Inflammatory Bowel Disease by Click and Ruggiero, looking at what does it take to make a medical home model effective, and a medical home model basically with a multidisciplinary team. So if you're going to have a gastroenterologist, nurses, nurse practitioners, a dietitian, and behavioral providers in the same clinic, all interacting with the patient at the same visit, you really need at least 1,000 patients, at least in the States, to make this cost effective. Assuming that about 300 of those patients are going to truly take advantage of everybody because of the complexity of their needs. You definitely need a physician, a gastroenterologist champion, and you need to be measuring things. So you need to use patient report forms, clinician forms. You need to think about when you're drawing labs, when you're doing those colonoscopies, and you need to put that all into your predictive modeling, that data set that I showed you, that capacity that we have, so that you're providing the right team resources at the right time for the patients and at the right intensity over time. So hopefully if you're doing your job and really hearing your patient, you don't have to stay at the same intensity all year, that as your patient improves, the team can back off, and then it can be much more maintenance and keeping remission. So this is our team, and the whole idea here is to get as much of the care at clinic really provided by our nurse practitioners, our social workers, and our dietary team. And then I'm there as a psychiatrist. The gastroenterologists are there. And we have 3 devoted gastroenterologists to this particular clinic, but we actually have made this available to any gastroenterologist in our system as long as they agree to coordinate care with us. Care coordination with the team is key, and we don't mean just, oh yeah, you're going to read our notes. If you refer 20 patients or more, we would like you to give us a half hour of your time once a month to meet with one of our team members and just make sure that you understand what we are doing to reinforce and we understand where you're taking the GI care. And we do this a lot of times by web, phone, and then both of us looking at the same information in the medical record. Everybody has their roles. I'm not going to go through this in great detail here, but please ask me questions at the break. But really trying to get everybody to provide the right level of care, but at the same time be mindful that we need to make this population health-based, because even our hospital system, they want us to be treating 2,000 to 3,000 patients with this core team of, actually there's 6 of us on the core team. And so we really need to optimize what we do. When we have clinic, we have 5 rooms at one time, and then we are all in a team room, and then we are coordinating care in that team room. So it sort of feels like an emergency department where we're sort of central control, and then the different folks are bopping in and out of the rooms. So it looks like organized chaos to an outside observer, and we get a lot of outside observers to try to learn from our model, but it really does work. And 5 complex patients in 1 hour is pretty good care. So we see 40 to 60 patients a half day. And that the hospital is pretty satisfied with that. So, and they are the ones that ultimately have to be involved in these decision makings. Here, probably your whole system. All right. So how do we fit in digital care? So I actually have my medical team triage from those questionnaires and the questions they ask patients about what patients need in terms of their behavioral health. And then our first line, if it's a good fit. And remember, some patients don't like technology. Some patients just have such horrific things going on that it's not appropriate to give them an app with the coach. But for the vast majority of our patients, actually they're very excited to have this tool. And actually, they talk it up in their chat rooms, and I presented enough to our local Crohn's and Colitis Foundation to patients. So we really have excellent patient buy-in. So patients really are appreciative, and then we're always also incorporating their feedback in our improvements. So digital care, and then only as a next step, our behavioral social worker, and then only if I've trained my medical team to handle sort of first line psychotropic approaches, and then only if the first line serotonin reuptake inhibitor or serotonergic noradrenergic uptake inhibitor or tricyclic didn't work, do they call in me in? And I'm really there more as a consultant. I mean, that's how I can be there to focus on the more challenging patients. And then my specialty in hypnosis happens to be trauma-focused hypnosis. So I also do more intensive work with some of our traumatized patients to really help them improve in the ways that they need to. And again, we have a feedback loop to make sure that we're monitoring that patients truly are improving. This is just a little bit of a higher resolution model of, so we've had 800 patients in the last 4 years go through our program. And when we take this, and this is information again, all of this we're drawing from our medical record. So we have demographic information. We have the number of encounters that we've had as a team, the comorbidities, the medications they're on, their hospitalization rate, their length of stays, the number of ER visits our program has had, and then which providers have actually written, if you write a note, you've seen the patient during that visit, so we can track who's seen which patient and for what amount of time. So all of that is available. I spend once a month, one whole day, staring at this graph and playing with it and looking for ways to optimize. And I'm helping our computer guys, because I'm not a computer person, build predictive models so that we can now find patients who would most benefit from us in our system. We only have 800. We have 6,000 patients in our system. So now we know which patients to reach out to. And then we also can track which patients we're not doing a good job with. They're still struggling in important areas. How do we change up care? And you see here and this really stays pretty consistent at our index visit, so first visit with our program. Almost 25% have clinically significant depression, almost 40% clinically significant anxiety. Of those, 40% have both. 60% of our patients at any one cross-sectional look are self-reporting pain that's at least moderate to severe. 15% are coming to us on opioids, and only 26% are meeting criteria by some objective criteria of either having a colonoscopy in the last year or blood lab values for C-reactive protein have evidence of active IBD. In terms of the pharmacology that we use, and this is a review article that I was part of, Doug Drossman was the lead author, we really use algorithm-based pharmacotherapy. We push to effect or tolerance, and we have sort of ways then that we change, and we don't keep somebody on a psychotropic that doesn't work. So often in other programs, a patient is put on something and then nobody's really watching, and they can be on it for 10, 12 years, and there really hasn't been effective. So treating to target is important. And then we have our own pain anesthesiologist, so anybody who comes to us on opioids, we ask them to work with this pain specialist. They have a pain contract. We're working, and the pain specialist is working and getting them on the lowest amount of opioids possible. And now we had medical marijuana legalized for Crohn's disease and ulcerative colitis in our state just a year ago. So it's not FDA regulated, and so this has now become a whole new area of niche research to really understand what our patients are taking, how much cannabinoid, and is it CBD1 or CBD2, how much THC levels are there, and what exactly is it doing to the brain, the gut, and also the interaction with the other medications that they're on. So luckily we have figured out a systematic way. We have them bring their supplies, and then we read off the label, because there's obviously we're not prescribing this, and we ask that our patients get their medical marijuana card through our provider. Again, so we can really understand what they're taking, how it's helping, and a lot of patient questionnaires on that. If we take our program, we have high patient engagement, high patient satisfaction with their care. I'm also interested in my team not getting burnt out, so I'm happy to report that our burnout rates, when we compare our to gastroenterologists and nurses that are not in this kind of collaborative, team-based care, that our burnout rates are lower and coming down. We reduce medical utilization continually by 50%, ER visits, hospitalizations reduced. We're having clinical impact on anxiety, depression, improved pain-related quality of life, and reduced opioid use. And my last couple of slides are focused on the reduced opioid use. So we all know that opioids are not optimal for chronic pain, and yet it's still, again, 26% of our patients are coming to us on opioids. So we looked over a couple year period, 2015 to 18, and I took all the patients who had been in our program for at least a year and who had come to us with at least 2 months worth of prescriptions of opioid medications. We used our depression, quality of life, IBD severity measures, and then we looked 12 months later, and then we were also able to look at whatever change there was, how much advantage did the patients actually take of the behavioral care that we offer. So I'm jumping to the point here. We had 104 patients, and this was out of a sample of, at that point, it was almost 500 patients, so quite a few were on opioids chronically. 72 of those patients actually came off opioids, and of those, 64% used what I would call our full program. So what we would have defined as a clinically significant amount of getting therapy, working with other non-opioid psychotropics, and working with our pain specialists to get off their opioids. And those patients had a significant improvement in both their pain outcomes, and that was so important. They came off opioids and their pain got better, as did their anxiety and depression. The 30% of patients who continued opioid use at 12 months, and it's a very small group, so we're only talking about 32 patients, but they tended to be a more minority, more female. They had higher baseline depression scores. They were also came to us on benzodiazepines, which they refused to get off of and stayed on, and they were much less engaged in behavioral services. Only 2 of the group who didn't come off opioids used our behavioral services. So again, it's small, but I think sometimes we have to start small to understand when we do have big data, and it's so exciting to hear about your big data initiatives. How are you going to look at that data in the best possible way? Because the thing about big data is you can look at everything and anything, and you can spend a lot of time looking at the wrong things. So it's really good to sort of have some clinical models and some models that are sort of in the messy real world, at least as a starting point. And I always say, and I am trained fully as a PhD in basic neuroscience, was my life before I decided to go to medical school. So I always tell my students, if you can't show a clinical signal in 60 patients, I'm not going to give you the money to try to look for it in 600. Because if we really want an effect size to be real, and either you didn't set up your experiment right, or it's not a real enough effect. So we do a lot of rapid trial testing of things in this model relatively quickly, and then if there's something there, then we're going to go and design it at another level of stringency and with a much larger sample size. So behavioral integration, I feel, is critical. The integration into medical care is valuable to patients. You can improve the quality of care. And now this program is going on its 5th year of existence. We were just given a $6 million grant to really study our model from a federal agency. And we are just now looking at cost data. Our medical system has its own provider, insurance provider. So we have claims data on all these patients. That's a whole other level of nightmare to truly understand, but worth for you to think about early in your process too, because ultimately that's what you need to show to really get both the political support and then the support within sort of the healthcare system to change things. And then last but not least, I really think there's a lot of ways that we can optimize behavioral therapies to our patients, and some ways now evolving with the use of technology to get these therapies to our patients, even if there's not enough mental health providers, and even if all of our patients can't physically come to us with the frequency that would be most helpful for their behavioral health. So thank you.
For a very impressive, let's stay there for a minute. We can't possibly let you come all this way and not ask you a few questions at least. So thank you, very impressive system, and I think it's a really sort of lesson for us all in how we could actually integrate this care much better. Do we have some questions from the audience? Has anyone got the microphone? Could you pass that back to Miles?
What a great service. You're to be congratulated, and I'm sure we would all love to have something like that. I may have misunderstood the mechanism that you have. So your gastroenterologists refer into your system. Is the first point in your system purely a sort of app-based thing, which doesn't have a sort of manual input to it? Do they get steered through a program which, if their symptoms match up, and they can just follow that by remote control without requiring input of people, as it were? Is that correct?
Partly, yes. So it's complicated because there's really two mechanisms into our system. Our referrals can be either from primary care doctors or other gastroenterologists. Some prefer to basically gift us their patients completely.
Yeah.
In that case, then, our gastroenterologist is part of the first visit, and as are all the ancillary providers. So in that model, it's fully disciplinary, and the first contact is a face-to-face visit with the team that takes about an hour to 15 minutes. For gastroenterologists who would like to keep their patients, but who would like access to behavioral care, dietary care, some emergency nurse practitioner access if their patients are in crisis, and often dealing with some of the symptoms that aren't really completely easily linked to an IBD flare, those will refer in, and they meet everybody on the team in an initial face-to-face visit except the gastroenterologist. So we have those two models. At that index visit, we have patients do a number of, probably about 15 minutes worth of questionnaires, and again, we just are having that available so they can either do it before their visit in the portal. They can do it at the visit, either paper to pencil or at the tablet. And then at that visit is after the team does their assessment. And we've developed actually, we've used care management tools, and we have a whole system of developing or deciding how we just, how a patient what a patient needs. Do they need behavioral health at all? At what intensity? Do they need nutrition and dietary consult?
So can I just, you're describing a really Rolls-Royce system, which is fantastic. Do you think there's any part of this that can be pulled out and a sort of plug-and-play module online for people who don't have access to psychologists, support work, and so on and so forth, which is your Rolls-Royce system? And would that be useful, or in your view, actually, is that just too cheap and actually potentially either damaging or not as useful? Where to go?
So in the $6 million grant that just got, we're testing that. Well, it's funny because I took a picture out of the plane, and I had no idea that my plane engine was Rolls Royce. I was like, oh, good. This is good. This is a good sign. Not crash into the pond. The grant is actually looking at a completely digital home. Right. So a patient doesn't come to us. They do get one-time visit telepsych, but then everything else, all of those services are remotely delivered by technology. So that's what we are looking at right now.
That'd be terrific to
I think, by the way, I think it is going to be portable, because once the patient gets randomized to that arm, their comment very quickly is we hope we never have to go back to the other model. So the patients actually love it. And I mean, obviously I haven't looked at the results, but my gut is going to tell me that the patients are going to have just as strong a response. And of course, they come when they have to. I mean, there are certain things that happen with your IBD that you really want to see somebody face to face, and you want to be right there, but close to the inpatient ward. But so I think yes, it is vastly available. And in the grant that I described, we're also having 2 other sites: Mount Sinai Medical Center in New York and Cleveland Clinic. And we're
And you'll be
Dr.
measuring
Durr.
pain outcomes.
And we are measuring pain outcomes.
Yes.
Okay, thanks very much. So when you look at your 800 patients who you tested on, are these people who've already bounced around the system a lot, or are they relatively new diagnoses?
We get the whole range. We do ask that somebody come to us already with a confirmed diagnosis of IBD, but you don't always get what you wish for or ask for. So we really have the entire range. I would say at least half of our patients are coming to us because they feel like they have been failed by the medical system elsewhere. So, I mean, it's an interesting population because the patient expectation is, oh, I'm going to try this, but it's going to fail too, because everything has failed.
So do you think would your expectation be if this was installed as a kind of like the first thing that a tertiary centre did?
Oh, absolutely.
It would improve your outcomes?
Absolutely.
Or do you think that because these people are worse, you've got more, as it were, you start with a high baseline, so you've got more that you can improve?
And that's why we don't turn anybody away, because, I mean, ultimately this is going to be most effective if we use it more preventively than reactively. I mean, yes, even though you don't have as much change score, but actually, because it's a lifelong disease, you actually can show that if you have less relapse and less disability and less suffering in the different ways that we measure that, that really is going to be a win. And ultimately, I mean, the healthcare systems that really only care about cost containment, or mainly only care about cost containment, really also invite that model because you can show actually the cost savings much faster. Often these patients, we actually, when we first looked at our costs, we looked at the first year, and we actually increased cost by $500,000 for a group of patients. But when we started to look at them 3 to 4 years down the line, which we now can, now we're showing actually really big cost savings. And again, this is with incorporating the cost of biologics into this model as well.
I'm really sorry, we're going to have to stop it there in the interest of time, but please carry on this conversation, this networking. Thank you for being with us.
Thank you for having me.